Okay, everyone. I'm going to make a start. We're about 5 minutes after the start time, and people may roll in. My name's James Seddon. I am a senior lecturer at Imperial, and I'm also a consultant in paediatric infectious diseases at St Mary's. And I'm talking to you from Cape Town. I live and work down here, and I come back to London periodically to do some clinical work. I've been asked to talk about TB in children, and I've given the title of The Easy and the Difficult. I don't know quite what that means, so I've tried to do some justice to this. And I'm going to go through and give you a bit of an overview of this topic. So what I'm going to try and cover in the next sort of 45-50 minutes is talk a bit about how many children there are with TB in the world. What does a child with TB look like? How do we diagnose children? How do we treat them? And then how do we prevent them? So I'm going to start with how many children are there with TB? And the kind of classical paradigm for thinking about TB is that children get exposed to TB and a certain proportion will become infected. And of those, some will get disease. And then depending on various other things, some will survive or die or have some kind of morbidity. And there are known risk factors which influence the risk of progression from one state to the next. And there are also certain interventions we can undertake to either prevent or increase the probability of the next outcome. But I think that recently people have really begun to question this more and more and see this as much more of a continuum with children moving along this progression. So children start off getting exposed, and then some will get infected, but then this idea of disease and infection as two distinct dichotomous states is not entirely valid anymore. Yes, Andy's just said, if anyone does want to add questions, I think it would be useful to add them as we go along. And I'm very happy to answer them as we go along if you find a natural break, or we can answer them at the end. So this continuum is more and more seen as the real sense, and actually as the bacillary load increases, you get more severe disease and more likely that you have symptoms and more chance of culture positivity. So how do we know about this this progression? And the best data we have comes from an era before we had any drugs, when this group of amazing doctors and scientists took a bunch of children and meticulously watched them from the time they're exposed to TB. They followed them up. They measured with tuberculin skin tests when they became infected, and they followed them up sometimes up to 20 years to see what actually happened to these children. This is a photograph of Edith Lincoln, who was one of the early pioneers in the US of early tuberculosis care. And these studies were reviewed relatively recently by a scientist called Ben Murray, who put it all together, all this pre-chemotherapy literature. This is a photo of Alfred Walgren, who was also another guy who did a lot of work to try and define the timetable of TB. And what you find is that after a child gets exposed and then infected, so we think there are bugs in the body, they have a positive tuberculin test, there's a timetable, and most children follow this timetable in some capacity. So you get a hypersensitivity phase where you get tuberculin positivity, and then if you're going to get miliary TB or TB meningitis, you get it quite quickly after a few months of getting infected and exposed. So you have a brief window after a child's been exposed to TB to prevent those severe cases. And then as time goes on, you start getting different characteristic types of TB in children. Ultimately, you then have the osteoarticular TB, and then the late manifestations, which look like more adult type TB, which happen maybe months or even years later. So the first question from my study is, in an infant, so a child less than a year, and they've got it been infected with TB, what is the risk of progression to TB? So I'm going to, I think, launch this poll. Hopefully polling is happening. So hopefully people have this in front of them. So please vote on which you think this is. So votes are coming in thick and fast. Had a couple of votes. We should have 4 or 5 votes. Okay, I'm going to do a bit of a countdown. 5, 4, 3, 2, 1. Okay, and we're going to share the results. And people felt that the highest chance is that 10% of infants who have been infected will go on to get disease. Okay, Now, this is from that paper by Ben Murray, which divided these children. And if you look at the under 1-year-olds, actually their risk of progressing disease is about 50%. So about 35% will get pulmonary TB and 15% will get disseminated, so meningitis. So that group of children are at incredibly high risk of developing both disease overall, but also this severe type of disease. And then the risk falls away into childhood and then rises again into adolescence. And if you combine all these risks together, you have the blue line, which is the risk of having a positive infection. And this is really a function of age. So as children get older, they have a higher risk of being exposed to someone who's got TB. And if you've ever been exposed to someone who's TB and you've got infection, it never goes away. So that's just a cumulative risk. But the risk if you've been infected of developing disease starts very high. As I showed in that previous slide, it drops this nadir in this age group, this primary school age group. And I read a statistic a while ago that's saying on your 7th birthday, you have the lowest risk of dying from any cause in the next 365 than at any time in your life. So this is the best age to be, 7 years, and TB is the same as any other disease. And then it rises into adolescence. And then also your risk of having a very bad outcome. If you're a young child and you have disease and it's not treated, you have a high risk of dying. But actually a lot of children in this kind of age group, even if not treated, often don't die of the disease. So the age is intimately related with TB progression. And HIV is also really, really important. So this is a systematic review and meta-analysis, and this is a forest plot which summarizes risk from many studies. And what it shows is that children who have HIV are nearly 8 times greater risk of getting TB than children without HIV. So that's across all degrees of immunosuppression. And then what you see here is the impact of antiretroviral therapy. So at the top is the risk of a child who's not on antiretroviral therapy, and you see it falls very, very quickly, so that at about a year, the risk is at about 90% reduction. So it's only about 10% of the risk that it was without it. So it doesn't go 100% back to normal, but it does fall very rapidly. So HIV is a significant risk factor, but antiretroviral therapy is important as well. So our next question on the poll, and we'll open up the poll, and we will drop down to the next question. And I'm going to launch this poll. So how many children globally develop TB each year, do we think? So the numbers are coming in thick and fast. It's a bit of a spread. Okay, I'm going to give you a bit of a countdown. 5, 4, 3, 2, 1. Okay, we're going to end our poll, share these results. So quite a good spread. So some people thinking 2 million, some 1 million, and then some fewer than that. So it's quite difficult to know how many children in the world have TB because there is a number out there, which is all the children, but that's kind of unknown. And then only a proportion of those actually ever go to a clinic somewhere. And even if they do go to a clinic, TB, and especially in young children, has fairly non-specific symptoms, overlaps other conditions. And so not all of them are diagnosed, and they often can't produce sputum, which is what's required for a confirmed diagnosis. And even those who are diagnosed aren't often and treated aren't often made their way onto the treatment registers and often aren't reported. So the numbers that the WHO, who provide these global burdens, estimates of burden, don't have numbers for all these children. So what they previously did, the WHO, up until 2012, when they first started reporting childhood burden of TB, is they said, well, we'll take all the children who report to us, which is about 350,000 a year, and we'll say we're not getting all of them, so we'll inflate that number by a bit. And they use that sort of same fudge factor they use in adults. And in adults, they had some idea that they were only getting about 2/3 of cases, so they increased the pediatric number by 1/3, and they said 500,000 children get TB. But over time, other groups have used slightly more sophisticated methods and modeling methods to try and estimate the burden. And what it's come down to is actually there's more consensus around the fact that actually about 1 million children each year get TB. But of those, less than half are diagnosed and put on treatment. So there's this big gap amongst children who have TB and those who are diagnosed and put on treatment. And it's not surprising that places that have lots of children have lots of TB, have lots of children with TB. So poor countries with very broad population pyramids. So that's from a global level. What about in England? If we have if we have 1 million children a year who have TB globally, how many children in England are going to get TB each year? Getting quite a spread of answers. 5, 4, 3, 2, 1. Very good. We'll share these results. So the consensus generally is that about 500 children in the UK get TB, but some people thought quite a lot more, and some people thought a few less. Okay. Right, so in the UK, the numbers have been going down year on year, and in England, these data are from Public Health England, not from the UK, because it's devolved. But in 2018, which is the 2019 reports on 2018 numbers, there were just over 4,500 people in total, and only 151 children were notified with TB in the UK. That may not be all of them, but it's probably most of them in the UK, because we've got fairly robust reporting system. So not that many children with TB. And but we do have, in metropolitan areas, some of the areas do have what's considered very high prevalence sections. So it's a very piecemeal area. So some areas of the UK, almost none, and some have quite a lot. And so you need to think about it quite carefully. And this is quite a lot of data, but I think it's important to look at what is the breakdown by age. And what I find striking about these data is in adults, the vast majority of TB is in people who weren't born in the UK. So in these age groups, you've got far more people with TB who are adults. But in the youngest, especially the under 10s, actually most TB is in children who have been born in the UK. Now, they may have parents who are not born in the UK, but it's just, if you have a child in front of you who has symptoms, you don't just assume that to have TB, you have to have come from somewhere else. So what does a child with TB look like? Okay, and these are some data from a rural area in Malawi, and I think that this is useful because it shows what the kind of natural history in a high burden setting looks like. And what you see is about 10% of the burden of the total TB burden is in children under 15, and just over half is in young children, and a bit older, and a bit under half is in the 5 to 15-year-olds. And very few of them have a confirmed diagnosis. Most have an unconfirmed diagnosis. Quite a lot have extrapulmonary TB, so TB either of the bones, of the abdomen, of the brain, of peripheral lymph nodes in the neck. So those are much more common than in adults. And I think what's quite interesting is that as you get as the transition goes from a poor country with a broad-based population pyramid to a more developed country with a more developed population pyramid, you have quite a different demographic. So you have quite a lot of cases in children, then it drops in this age group I showed you, and then it rises with men having more than women here. And this is a more developed population with lower rates in younger people and rising. And what you also see is that this is a log scale, so the rate here is 10 per 100,000. This is something like the UK, and then 100 per 100,000, so this is a middle burden country, and then 1,000 per 100,000, which is a very high burden country. And what you see is that as the prevalence and incidence of TB in the country goes up, you have an increasing proportion of that burden that's in children. So in somewhere like the UK, only 5% of TB is in children, but in a place that, like South Africa, which has very high rates of TB, actually you're seeing a much higher proportion of the rate. And that's partly because of this broad population pyramid. It's also because the force of infection is so great that children get exposed at a young age, and so that they, when they're at that high risk of transferring, progressing to disease. And what do you see? What types of TB do you see in kids? So you see we've seen this U-shaped spectrum, but what is this made of? So it's made of children generally either have this very limited disease of hilar lymphadenopathy in an intrathoracic way, or they have very disseminated disease, miliary TB, TB meningitis. And then in adults, as they start getting older, they develop, this is what you classically see in adults, very high bacillary burdens, cavities, and lots of bugs within the lungs. And so these two different types fall away. You have less and less of this porcibacillary limited TB, and you have less and less of the disseminated disease, and you get more and more of the adult type. So there are almost two different epidemics. There's an epidemic of not enough immunity in children, and there's an epidemic of too much immunity in adolescence and adulthood. And almost just superimposing these two epidemics on each other, you get this U-shaped curve. And so these are some chest X-ray images. So this is hilar lymphadenopathy in a child, and then this is a more complicated breakdown in a hilar lymphadenopathy. You get disseminated seed is a classic picture of miliary TB, the millet seed that you see. And then as children enter adolescence, you quite often see pleural effusions. And then this is a classic picture of cavities and breakdown, an adult type picture. Lymph node TB is very common in children, so especially lymph nodes in the neck and sometimes in the axilla, and the old term scrofula was a term for lymphadenopathy in children with TB. You can get TB almost anywhere. This is a child I've seen in Cape Town with very, very severe, this is prior to surgery, this is after surgery, and it was a miracle this child was neurologically intact. You see their sort of spinal cord being totally worn away, a couple of vertebrates totally destroyed. You can get TB almost any of the bones and joints, most commonly spine and hips and knees, but really anywhere. And meningitis, the most horrible disease that you can imagine. It's a child I saw actually in the Ivory Coast, and you get just it's a miserable illness. Even children who you diagnose it early and treat, that there are almost always some long-term sequelae and very high rates of morbidity and high rates of mortality. About a fifth of children who get TBM, even if they're diagnosed and treated, die. So how do you diagnose a child with TB? And this is, again, quite busy, but generally children present to you through one of three routes. So either they present to you through contact tracing. So you've found an adult with TB and they've screened all the children in the household and they've found the child contacts, or someone's referred a child to you because they've got an abnormal X-ray or an abnormal IGRA test or something and you need to make sense of it, or they present with symptoms. And the first job you always have to do is say, do they have TB disease? That's the first job. And if they have TB disease, and I'll talk a bit about how you evaluate for this, you then need to go down the route of managing that. But if they don't have disease, that's not the end of your job, because if they were referred because they had symptoms, you need to figure out what is causing those symptoms. So looking kind of at the, I've lost my cursor somewhere, you need to decide what is responsible for those symptoms. If they were referred because they were a contact, you need to then say, well, do they need preventive therapy? And we'll talk a little bit about that at the end. And if they're referred because of an abnormal test and they don't have disease, well, maybe it's because they have infection, or maybe you need to figure out why they've got an abnormal X-ray or a positive IGRA test. And there are various things that impact on those decision making, and I'll go into those in a bit more detail. And there are two ways of diagnosing TB disease in children. Really, you look at the host response to the organism, or you try and find the organism itself. And classically, we take a history, we examine the child, we look for radiology, we might do some immunological diagnostics, and then finally we try and find a bug and we look for microbiological diagnosis. And if we do get a bug, we really want to know if there's any drug resistance. And we always want to know if there's HIV present, because that has a huge impact on the presentation and treatment of TB in children. So starting with the kind of host response bit. So the classics, so as I've mentioned, there are three ways they really present to you, but the symptoms are quite challenging. But the ones that we really need to look out for are this chronic unremitting cough for a number of weeks, fever that's going on for a long time, and you've looked into other causes, weight loss or failure to thrive, and then sort of fatigue or not keeping up with other children. Those are, I mean, they're very non-specific, and there are lots of other causes of these, but if you have these, you need to really have TB on the radar, as long as there's, especially if there's epidemiological data on it. Lots of people have proposed scoring systems, which have generally not been found to be very useful. This was a nice study, again, by this guy, Ben Murray, who looked at different types of cough. So the characteristic of cough is really important. So you've got three types of cough here. You've got the kind of recurrent acute cough that goes up and comes down. You've got the acute cough with delayed recovery, and then you've got this persistent non-remitting cough, which is getting worse and worse. When you're taking a history, it's very important not just to ask whether they've had cough or not, but really go into the characteristics of the cough. Because when you define what the types of cough are, it really will distinguish the types of disease in a reasonable way. And so having sort of airways disease, you're more likely to get these kinds of cough, and some some viral infections might even last a number of weeks, but they often will be gradually getting better if you go into the details. But this is the kind of cough that you really don't want to be missing. In terms of X-rays, actually, I mean, I've kind of spent a lot of time thinking about X-rays and trying to work out what X-rays do in the type of TB, but there are certain features on X-ray which really help you. If there are hilar lymph nodes, there are not that many other things that can cause hilar lymph nodes in the context of a child who might have other risk factors. Cavities, again, really should point you towards TB. The miliary pattern I've described is very suggestive. And those are kind of features which, if you see those help you. But a lot of children with TB have sort of much less specific signs, and for those, X-ray isn't really moving you one way or another. It's telling you there's something wrong, but it's saying it could be TB, but it's not telling you either it isn't or it is. And this is a study that said that even to diagnose this characteristic feature of hilar lymphadenopathy, different readers really have very different impressions. And when you compare them to the gold standard of having a CT chest, actually sensitive and specificity are not brilliant. So chest X-ray I think is a useful tool, but I think people often overplay it and think it's can do everything, and often it's useful, but it's one piece in the jigsaw. What about these tests? So this is the tuberculin skin test, and these are the interferon gamma release assays. I think that these tests can't tell the difference between TB infection disease. They just tell you that the child has seen bits of the TB bug before. They test the type 4 hypersensitivity response. So it says that there is a T cell memory to TB antigens. So they can, if you've got a symptomatic child and you've got one of these tests, it kind of nudges you towards TB rather than other diseases, but it doesn't, they could have pneumococcal pneumonia and have been exposed to TB and just have latent infection. You get false positives with the TST, and you can't rely on a negative test, because there are some children, about 20% of children with confirmed TB disease will have negative tests. And they can be expensive and require X visits, and so these are another piece in the jigsaw, but they're not perfect. So this is an exciting area. This was first described by the group at Imperial, led by Mike Levine. So using gene expression to look at which genes are switched off and switched on. So looking at messenger RNA. So if you take a snapshot of which bits of messenger RNA there are at any one time, that tells you which genes are activated, and every disease has a different signature associated with the immune response to it. And I think this is the direction of travel. I think that this is moving forward, and this was published 6 years ago, but already this has been evolved. And I think that we're not too far away from having point of care tests, finger prick tests that will say this child likely has an immune response which is characteristic of TB, versus this child who has an immune response which is characteristic of a viral infection or a bacterial infection of other kinds. So I think this will be a way we'll be moving forward going forward. It won't be perfect, but it will probably be better than what we've got at the moment. So moving on to the microbiology, next question in our quiz. So what proportion of children with TB disease are likely to have a culture confirmed diagnosis? 5%, 10%, 30%, 70%, or 100%? This is a slightly tricky question, because actually it totally depends on how many samples you take, how old the child is, how severe their disease is, how hard you try, what kind of tests you do in the lab. But generally, in good studies where they take lots of samples and they evaluate children, we tend to see a relatively consistent pattern. And what people are seeing is that that 10% is what we're seeing, and quite a few with 30 and 5. Now, I would say that probably, just to go back, that probably 10% is actually accurate in routine practice, but I think in the context of a very well investigated group of children, you're more likely to see 30%. So what do we do? Well, we first of all need to take a sample, then you need to do something with that sample, then you need to do your test, and then you need to look for it. And we can get lots of samples from children. So the ideal is they cough spontaneously into a pot and you look at it, and that's what we do with adults. But children under 5 or 6 are not able to do that. So we have to be creative. And the theory of sampling, either we can stimulate them to cough and we suction the sputum as it comes to the top of the oropharynx, or with some kind of aspirate, or we put a tube into the stomach first thing in the morning, and we assume that they've been coughing all night and swallowing their sputum. And if you suck out the abdominal, the stomach contents before they wake up and are fed, and before peristalsis kicks in, and if you aspirate all those contents, then you're really getting a yield from all the coughs that they've had overnight. So we're beginning to see that. Which is better, this induced sputum, which people have done more and more of, where you give a hypertonic saline nebulizer and then you aspirate, or the more traditional gastric aspirate or gastric lavage, The bottom line is in expert hands, they both have relatively similar yields. And I think it depends on the expertise of the group that you're using. The more tests, the better. And often people use a hybrid where you get one sample from an induced sputum when they come in, you maybe keep them in overnight, one night, do a gastric aspirate first thing, and then a few hours later do an induced sputum and get them home. And I think that's a reasonable sampling method to get a few samples from children in a short time. Stool is increasingly being excited. People are getting excited by stool. Again, the theory is you cough and you swallow your sputum and it comes out in the stool, and it may not be viable bacteria, but with a PCR test you might be able to detect bits of bacteria. And actually the stool, when you look against a reference standard of some kind of pulmonary sample, it's not bad, about 60% odd, but actually when you look at a clinical reference standard, it's relatively poor. And this is just going alongside that actually respiratory samples are also quite poor when you use a reference standard of a clinical diagnosis. But actually, in terms of if you want something that's relatively easy to you get a quick diagnosis, it's not a bad option. And so increasingly people are thinking about using stool, and they're using different stool processing systems to get increased yield. And I think that going forward, we probably will have this as a first-line test to try and identify TB in children. Once we get it to the lab, so we've got our respiratory sample, we've got our stool sample, we can either do traditional microscopy with Seddon staining, or we can do fluorescein staining. So these are sort of the old style. This is what people did in the past to try and actually look for the bug, but you need a lot of bugs in that sample to see it. Then culture, you can either have culture on the traditional plates, the solid agar plates, LJ plates, or more and more we're doing liquid culture, where you have a bottle of culture media, like a blood culture bottle, and you put the bacteria in there, and the yield is higher, and B, you get a result much quicker. With the plate culture, it might take up to 6 weeks, definitely kind of up to a month, but this can be a couple of weeks for your liquid culture. And this is the new kind of mechanism. So all of the testing is going to molecular. In the UK now, all testing is molecular. And in the UK, it's all whole genome sequencing. They're sequencing the entire genome of the bacteria. Often they culture it first and then sequencing, but they can do it on clinical samples as well. But this Gene Expert test is a sample which is now in the field and can be used at the point of care, either in every lab or even in a clinic. And you put the sample into this cartridge, you put it in a machine, and within 2 hours you get a result. And not only does it tell you whether you've got TB or not, but it also tells you whether you've got the main mutations that suggest resistance to the key antibiotic rifampicin. So this has now been rolled out globally and is increasingly available. And although it's not perfect, it's pretty good, and it does help get a result quickly. But there is this relationship between severity and age. So generally, as children get older, they get more severe disease with higher bacillary loads, and that impacts on your chance of getting a confirmed diagnosis. Also, sampling is affected by age. So generally, the younger kids are less likely to have a confirmed diagnosis, and older children are more likely to. And to summarize it all, if you have 10 children who you are planning on treating for TB, who you think, when you put the whole picture together, you think they do have TB, probably only 1 in 10 are going to have a positive smear on a respiratory sample. Maybe 2 out of 10 will have a positive expert test, that molecular test I told about, and maybe 3 out of 10 will have a positive culture sample, which is still the gold standard. So we're still left with 7 out of 10 children who we think have TB, who will be microbiologically negative, who will be unconfirmed in that respect. And I think we have to make peace with the fact that a lot of children will remain unconfirmed. And what it goes down to still for TB, until we have these gene expression assays, which are going to be developed, is it's putting a jigsaw together. You take your history, your examination, and you look at any immune tests you have, TST of the agar, you look at the X-ray or any other imaging. You try and get some microbiology, and sometimes time is really important. So either just waiting a couple of weeks. If it's pulmonary TB, usually, especially in a child who's older than 2 or 3, you have got a bit of time to wait. And a course of antibiotics that might treat bacterial causes, and then the time will effectively manage any viral causes. If people still have symptoms and abnormal chest X-rays a couple of weeks later, you have more confidence this might be TB. So how are we going to treat children with TB? Okay, so next question on our quiz. Oh no. Here we go. Back onto our poll. So I'm going to ask you about TB meningitis, drug susceptible TB meningitis. How long does WHO say we should treat this condition for? Okay, we're getting quite a lot of answers. 5, 4, 3, 2, 1. Okay, and so most people are saying 12 months, which is correct. That is what the WHO, not everyone does that, but that is what the guidance is, is showing. So WHO, these are the most recent child TB guidelines, published a few years ago, due to be updated this year. But they have suggested these dosages of the 4 first-line drugs, isoniazid, rifampicin, pyrazinamide, and ethambutol, at these dosages, which were increased from a few years ago. This nomenclature suggests 2 months of isoniazid, rifampicin, and pyrazinamide, and this is with ethambutol. And you can see that for TB meningitis at the bottom, you're supposed to give 2 months of those 4 drugs and then 10 months of isoniazid and rifampicin. So the whole treatment duration is 12 months. This is quite exciting. So traditionally, we've given sort of 10 to 15 milligrams of rifampicin. This is a study which should be published this year. It's finished. It's called the OptiRIF trial. And in this study, children with normal TB, drug susceptible TB, were given a normal regimen, and then they were given a higher dose of rifampicin for 14 days, and then a very high dose of 35 milligrams per kilogram on 1 day. And that was the first phase, and that was done. And pharmacokinetic studies were sampled at various time points on day 7 and day 14. And then with this higher dose, they were also sampled, and safety was recorded. And then once that was analyzed, a second study was done where 35 milligrams were given every day for 14 days with a one-off dose of 50 milligrams per kilogram. And that's been evaluated and was found to be safe, and the PK was evaluated. And then a third cohort was done where children were given 60 milligrams per kilogram per day for 14 days, and then a standalone dose of 75 milligrams. Now, this is like 5 or 6 times what the dose that we're currently giving. And children felt a bit unusual on this, but there were no overt safety signals. So I think that in the future, we will be going to be using dosages like 30 to 50 milligrams of rifampicin. And rifampicin has a fairly linear efficacy line, so that as you increase the dose, it increases killing. So I think that by using these higher dosages, we will get much greater killing. And I think that the likelihood is that we'll be using higher dosages, and this could lead to treatment shortening studies going forward. So this was a study which has finished this year, the SHINE trial. So taking children with limited disease, so children who didn't have cavities, didn't have smear positivity, didn't have extensive parenchymal disease, and they were randomized to either 6 months or 4 months of treatment, just pulmonary disease. The results of this trial have been presented confidentially, and the results will be presented, I'm sure, fairly soon. If this is shown to be non-inferior, so 4 months is found to be as good as 6 months, then I think a lot of children, at least 2/3 of children, have this minimal TB. And so for a lot of children, if this is found to be non-inferior, we will be able to get away with shorter treatment for children with drug susceptible TB, which again, it's not absolute massive game changer, but it's for families who are battling to get these drugs into children, 4 months is definitely better than 6 months. And this is a trial looking at TB meningitis. So the WHO standard of care is 12 months of treatment with standard drugs. So you can see at the bottom, the control arm has that standard regimen and standard dosages. And then the intervention arm is going to give higher dosages of rifampicin and isoniazid and pyrazinamide, and levofloxacin instead of ethambutol, because ethambutol doesn't get into the CSF very well. And it's just going to give all the 4 drugs, but for 6 months, and then it's going to stop. So it's going to see again whether this shorter intensive regimen is non-inferior to this longer regimen, and also it will see if aspirin with its antithrombotic and anti-inflammatory can prevent ischemic stroke in children with TB meningitis. This trial is just starting up in a number of sites in Africa and in Asia, and results should be available. So I think that we should be in the future, if this is non-inferior, have better treatments for drug susceptible TB, for pulmonary TB and meningitis. What about drug-resistant disease? So this is a systematic review and meta-analysis of children treated, about 1,000 children treated for Mdr Tb. So that's TB where the bug is resistant to isoniazid and rifampicin. And what this found actually is that treatment outcomes are very good. So in adults, only about 50 people with Mdr Tb have good outcomes, whereas in kids who get diagnosed and treated, well over 90% have very good outcomes. So I think this shows that if you diagnose and treat these children, they do well, but the treatment is quite long and quite toxic. And moving forward, we need to be sort of thinking about shorter treatment. So in terms of how to construct a regimen, we're on to our next poll. And if I can look, and we'll drop down here. Right, which of the following is not a group A or B drug for the treatment of Mdr Tb? So we've got bedaquiline, amikacin. Oh, sorry, let me launch the poll. Bedaquiline, amikacin, linezolid, levofloxacin, or clofazimine. So I think a lot of people are very comfortable with the first-line drugs. They know them quite well. They know that you treat children with isoniazid and rifampicin and pyrazinamide and butol. But when you get into MDR, it becomes a kind of different world. And there are lots of new drugs coming through and lots of new regimens being trialed in children and adults, which is quite exciting. Okay, 5, 4, 3. I think there are still people who haven't voted. 2, 1. Okay, and sharing results. So most people think that bedaquiline is not one of the core drugs to treat Mdr Tb. Well, actually, bedaquiline probably is the core drug now. It's the group A drugs are the fluoroquinolones, levofloxacin, amoxicillin, bedaquiline, and linezolid. That is now considered the absolute backbone of Mdr Tb treatment. Unfortunately, we can't give bedaquiline in all children because we don't have pharmacokinetic and safety data on the youngest children, so our children under 6. But anyone from 6 years on, we should use this as a first-line treatment along with linezolid and a fluoroquinolone. And then the second, the group B drugs, clofazimine, that's a spelling mistake, cyclozine and taurursine, which is kind of the same drug. And then we get into the group C drugs, and you really want to construct a regimen that has at least 4 of these drugs. And the injectable agents, amikacin and streptomycin, which previously were very much core to Mdr Tb treatment, have now been relegated, and they've been found not to be very effective and associated with high toxicity. So a large proportion of children who treat these injectable agents develop hearing loss, and that's just catastrophic for children who have the whole of their education and development and relationships to form and things. So we've moved a long way away from that. So this is how you construct your regimen for Mdr Tb. And the new drugs, bedaquiline, delamanid, first new drugs that have been developed in many years, are coming through, and we're increasingly using linezolid, which has been repurposed, the fluoroquinolones repurposed, and clofazimine, which is a leprosy drug. So treatment is changing quite a lot. And this is a trial which is about to be started in children with Mdr Tb. And instead of 18 months of treatment with 6 months of an injectable agent, we're hoping to move to a 6-month regimen. So children who will have 2 months of linezolid and levofloxacin, bedaquiline, and delamanid, and then a 4-month continuation phase of just these 3 drugs. Because linezolid, although it's very, very effective, is pretty toxic. So you then have only 2 months there and a longer tail. And the trial would be really just a phase 2 trial to look at safety. But I think that this would be a real game changer. If this is shown to be fairly effective and safe, I think people would be moving to a 6-month treatment for children. Okay, and the final section is how do we prevent children from getting TB? Well, the fundamental thing is we need to just make every country richer, because as countries get wealthier, the rate of TB just falls dramatically. So this is such a disease that is intimately related to socioeconomic status and poverty. But we can't really do that very easily, so we have to think about other things. What we found is that the rates of TB have plummeted in the UK over the last 100 years, 150 years, and really we only started developing TB drugs in this stage. So all of this fall was prior to the advent of vaccination or therapeutics, because vaccines and treatment only came in after the Second World War in a large scale way. This is not the case for many countries in the world who are still somewhere on this trajectory up here. So what can we do? Well, we can do some contact tracing. And the first question is, if you visit the house of a drug susceptible TB patient and you screen all children under 15, what proportion of those children will have TB disease. So they're sick with TB at the time you go into the household. You sort of screen everyone with x-rays and symptoms and everything else. Okay, we've got a really good spread here. Okay, 5, 4, 3, 2, 1. Okay, I'll share these results. Okay, so we've got a massive spread from 1% up to 12%. Okay, we're going to do, I'm now going to move on to the next question, and then we've got a different poll. And for this poll, we're going to say, if you visit the house of a drug-susceptible TB patient and screen all children, what proportion have evidence of TB infection? So they're completely well, but they have a positive skin test. So votes are coming in thick and fast. Okay, quite a spread. 3, 5, 4, 3, 2. Lots more people voting this time. I don't know why. What were you all doing before? Okay, and there's been a kind of most popular result here is that about 25% of children will be infected. Okay. So if we look in the left, this is a systematic review and meta-analysis that looked at the top, it's TB disease. So if you looked at all children, about 7%, if you go into a household, about 7% of children will have disease. And this is actually not different in the UK or in any other context. If you go in the household of an active case, and 7% is a lot. So that's it's one of the most efficient ways of finding cases that you can. And the other advantage of doing this is you find them early. So you don't wait for them to develop the symptoms and present to hospital, by which time a number of weeks have gone down. You catch these children early when they're at a more limited stage of disease where you'll be able to treat them successfully and they'll have very limited lung damage. So this is good for finding cases and finding them early. And then infection. So if you look at this again, under 15, about 40% of children will have a positive TST. And a positive TST is a substantial risk factor for getting disease in the next year or two. And this was a recently published review of children who have been found in their household. And you look at the risk in those who had a positive skin test, the risk in those who had a negative skin test, and then the total risk. And you see that in young children, their risk is about, in 2 years, about 20% getting disease. So if you go into that house and you find 40% of those children have a positive skin test, or 30% in the youngest children, they've got a real 1 in 5 chance of developing disease. So giving them some treatment to prevent disease is really efficient. And in fact, all of these kids have a 10% or so risk. So there's a huge incentive to get in there and treating them. Even children who have a negative test have a substantial risk as well. So doing household contact tracing and then treating with preventive therapy is really important. This is the classic isoniazid preventive therapy. If we ignore these two at the top, which were done in young children, so infants as pre-exposure prophylaxis, isoniazid is very effective. If you give it daily for 6 months, it substantially reduces the risk of disease progression. But things are moving in this space, and actually this is a big trial of 4 months of daily rifampicin, just one drug on its own, and then done in children, and it was found to be as effective, if not more effective, and very safe. In the UK, we use 3 months of isoniazid and rifampicin. That's as safe and as good. 3 months of daily rifapentin and isoniazid. So this is only once a week. So you only give 12 doses. So you give it every Sunday for 3 months. 12 dosages is as good as 9 months of isoniazid, which really should be easier to give. And then this is very exciting. This is 1 month of daily rifapentin isoniazid. So this is just in HIV infected adults, but it's being rolled out for pretty much all adults now, and the trial's going ahead in children. So we're thinking that we might have a preventive therapy regimen that will just be daily treatment for a month, which I think will be a real game changer, because I think everyone accepts that 6 months of daily therapy is almost impossible to give. So moving forward, I think that the treatment for drug susceptible TB infection is going to be easier to give. What about Mdr Tb infection? This is kind of my area of interest. So this was a systematic review that looked at the impact of various observational studies. I mean, these are all observational, but seem to suggest a substantial risk reduction, a 90% risk reduction of getting disease if you give children who have been exposed to Mdr Tb some kind of preventive therapy, usually involving a fluoroquinolone. they will have a reduced risk of getting disease. And there are a number of trials going ahead at the moment which should answer this, that will give us a definitive answer. So what can you be looking at? I would, if you're interested in TB, look at the WHO guidance, both the drug resistance and drug susceptible. There is a very good guide from the International Union Against TB and Lung Disease about TB in children. There's stuff from the WHO with training resources. There's a very nice online training course that the union provides both for TB and for Mdr Tb in children. And the Sentinel project, if people aren't members of the Sentinel project, it's free. You can just sign up and you can have an access to a whole load of resources and newsletters and things like information about drug-resistant TB if you're interested. So I'm going to stop there, and I'd be delighted to answer any questions from anyone who might have some. So Andy has come up with a question about and we've got kind of 10 minutes or so, definitely happy to ask some questions. What constitutes a positive TST with and without a prior BCG history? Do you follow NICE 5 millimeters irrespective of the BCG? And this is a very contentious, and we could probably talk for about an hour on this question, Andy. The WHO suggests that 10 millimeters is the right cutoff for all children, irrespective of BCG, unless they're HIV infected, where they say you should use 5. BCG definitely does impact on TST responses, especially in the young children, in children under 5. I think that children over 5, if you've got a TST response that's above 5 millimeters, you need to take it seriously and can't assume it's BCG. But at the same time, if you've got a younger child who's got a positive TST, you can't assume it's BCG, because it could be caused by BCG, but it could be caused by TST. So having a 5 millimeter is a very sensitive test, but it's not very specific. So, I think it depends what you want your screening to do. If you want it to be very sensitive and really not miss any and pick up everyone, then I think it's fine to use 5, but you need to then make peace that you're going to probably overtreat quite a few children. A lot of the time you use a TST at 5 and then follow it up by using an IGRA. So you use a TST in everyone, use a 5 millimeter cutoff to move into the next phase, and then use an IGRA to confirm it. But I think it depends what your screening test, what you want your screening test to do. So Claudine's asked, how does BCG help? What happens if you do not react? Well, I can answer the first, but I can't answer the second part of that. So how does BCG help? Well, actually, I can't really answer that. We don't really know how it helps. I mean, it's a bovis, Mycobacterium bovis, that has been heavily attenuated over 10 or 20 years in the 1910s and 20s, and so it became non-pathogenic. So in theory, you inject it intradermally, and it stimulates parts of the immune system, mainly the adaptive immune system, so that it's more responsive to TB. I mean, I think that the specific mechanisms of action are still poorly understood, but we do know from lots and lots of studies it does work, and it works particularly in young children, and it's protective of TB meningitis. So big studies have been done to say that it protects young children, and it stops rates of TB meningitis. And we recently had an episode in South Africa where there were stockouts of BCG, global stockouts, and for a 2-year period there weren't any BCGs given, and we saw a massive ramp up in the number of cases of TB meningitis, like 3-4 times as number in the preceding 10 years. So I think there's really no doubt that BCG does that. What happens if you don't react? So I've had 4 BCGs. The first 3 I didn't respond to, and I've just had one recently as part of a coronavirus trial. I volunteered, and I'm pretty sure I got the BCG rather than the placebo, because my whole arm did swell up and I've got a massive scar now. I don't think we know whether there's a different immune response in those who scar and those who don't scar. I think having had it, it should be considered that the child has been given the vaccine, because I don't think there's any evidence to suggest that not having scarred is a different response, but I don't think we know that. Any other questions? Either put your, you can either put them in chat, or you're welcome. There are not too many people, so you're welcome to just speak if you want to as well. Any other questions from anyone?
James, I'll ask another one while we're waiting. Certainly in the adult literature, when TB multi-drug resistant and extremely drug resistant TB came along, there was a recrudescence of the use of surgery for TB from the old days when there were no TB drugs and surgery was it. Any comments on surgery for tuberculosis in children? Any role at all?
No, I think there probably is a role. There was a big systematic review that was done to inform a WHO guidance that came out last year for the MDR guidelines, and this was all mainly in adults. But it really did show that if you have extensive disease in one isolated lobe with total destruction with cavities, that actually removing that lobe of the lung was quite effective. And then because if you have a massive cavity, the blood supply and the penetration of drugs in that area is very poor. So removing it is very effective. So I think in young children, there's probably very little role because very few of them have that kind of disease. But in adolescents who have extensive disease with a focal area that's effective, if you have widespread disease, then it's not very helpful. But if you have a focal area that's effective, I think speaking to your cardiothoracic surgeon is probably very sensible. And we had a very nice talk from it at the PTB meeting a couple of years ago from a thoracic surgeon in Birmingham who's done a few adolescent cases. So there's a question coming. What's your experience of drug adherence for young children with TB? Again, this is challenging, and it totally depends, as all medicine does, on your relationship with the patient and your relationship with the parents. And I think that if you can persuade the parents that that it's important and the risk is high and the disease is nasty, and you give them lots of tips and tricks as to how to get the drugs into the children, and you give them lots of resources to help support them, and you have very, very motivated nurses who ring them regularly and give them lots of education support, then your adherence can be excellent. If you just throw the pills at them and say, see you in 4 months, then invariably it's not very well taken. One thing I would say is that there's been a couple of years ago, there was a development of child-friendly formulations. So up until recently, we used adult formulations, or there weren't any child-friendly formulations, which had to be broken and crushed and dissolved, and they tasted disgusting. And that's what everyone used. But actually, we now have very nice pediatric formulations which disperse in water. So you drop the tablet in water, it dissolves, and then you just suck out a syringe with the appropriate amount to give you the right dose. It's very accurate. Tastes of mango, it's delicious. The only slight problem with this is these drugs have been developed mainly by grants from the US and the UK and from the EU, but they are not available to these countries because they have to be registered with the EMA and the FDA, and it's incredibly expensive for these generics who have made them. So a lot of companies in India who have developed these drugs, so we're in this weird paradoxical situation where these very nice child-friendly formulations are actually available to most countries in the world, but they're not widely available in Europe and North America, which is strange. So adherence would undoubtedly be better if we had lovely, tasty drugs that kids wanted to take and were easy to prepare. And it would be easier if it was only a month, and it would be easier if it was, once a week rather than once a day. So it's a complex talk. Any final questions? We've got kind of 2 minutes left. Andy's said that next week Liz is talking about PIMS, and unfortunately not the drink that we have at Wimbledon, but about COVID, and she is like literally the expert in the world on PIMS, so I'm sure that will be an excellent talk. I might even tune in myself and learn something about it. So in the absence of any of that, thank you all very much for attending early on a Thursday morning, and if you have any queries or questions, or you want any TB help or advice, I'm always happy. I can't promise I'll have the answers, but always happy to receive emails or questions. Thank you all very much. Goodbye.
Thank you very much, James.
Thank you very much indeed. I hope that went okay. I hope the polling, I think, was fine, wasn't it?
It was brilliant. I mean, perfect. Thank you for doing that. It was great. No, it really...
And time-wise, we're kind of okay, I think.
It's strange though, like you say, isn't it, that some people